Good morning, respected seniors and my colleagues. Today we will be discuss about the very commonly affecting the disease in our day-to-day practice. This is hypertension. Uh, Around 1 in 3 Indians are affecting from the hypertension. So it's a very common disease. And among, despite of this common disease, the very few are taking the medications, and even if they taking the medications, the control of the blood pressure is very less. So they are not taking effective dose, not doing the regular checkups. The reason for this more prevalent hypertension in Indian patients are poor diet. Our diet is in high sodium intake, lack of physical activity, stress, addictions in form of the tobacco, alcohol, and also we as a Southeast Asian, the high genetic and family history is also a culprit for hypertension. So adrenergic hypertensive diabetic India. Because of this very common problem, so what should we do? Let's discuss the guideline. There are too many guidelines, so which to follow? We will discuss the most common guideline like ACC-AHI guideline, ESC guideline, and our Association of Physicians of India API guideline. Recent guideline which is published is a ACC-AHI guideline in the 2025, while the ESC and API guideline was published in previous year. So what the European Society of Cardiology guideline, what is the change, what is new? So from the 2018, the arterial hypertension was removed and replaced with elevated BP and hypertension. The reason arterial hypertension was compromised, what consists of the pulmonary arterial hypertension as well as systemic hypertension. So in the recent guideline, the arterial hypertension was removed, and instead of this, elevated BP and hypertension was new terminology. Hypertension mediated CV risk is due to the continuous exposure of the elevated BP to individual. So elevated BP category was introduced. Target BP threshold was lower. Previously it was 140 by 90. Recent guideline, because it's a curvilinear risk, it was now, it's recommended less than 130 by 80, preferably systolic blood pressure between 120 to 130. Because risk is although more if beyond the 140 by 90, but it is also in the elevated group of the blood pressure, risk is also still there. Sex and gender are considered as an integral part of the guideline. So hypertension is women is undertreated. So this we should focus also in men and women both. The renal denervation has been recommended for treatment in a selected group, not in every group, because it doesn't decrease the mortality, it only decreases the pill burden. So, but in the recent guideline, renal denervation is also included. Although it's class 2B indication, low dose combination therapy is recommended. Previously, we are using combination therapy since many years, but European was not keen for using, but nowadays because of the compliance and adherence, the low dose combination therapy is recommended. Renin-angiotensin blockers, CCBs, diuretic are a first line therapy, and beta blocker are need based. So beta blocker are not for each and every patient. First are renin-angiotensin blockers, calcium channel blockers, diuretics, and then aldosterone blockers, and beta blockers only need based. So beta blockers is not a first line therapy. So these are the changes in a ESC recent guideline. What is the changes in the ACC-AHI guideline 2025? So risk score, prevent risk calculator score, they included the stronger linking of the hypertension control with cognitive decline and dementia prevention. So because of the dementia prevention also, we need to focus on the control of the blood pressure. Inclusion of the renal denervation is like in the ESC guideline. More uniform treatment target, less than 130 by 80 as compared to the previously 140 by 80, because the group between systolic blood pressure between 130 to 80 and diastolic between 80 to 90 also carries a high risk. So it is not more than 140/90 carries a more risk, but even in the elevated BP group, there is a risk. So the threshold for the target BP is lower from the 140/90 to 130/80, same like ESC guideline. Across the age and comorbidity strata, so patient with a more high risk, more lowering of the BP is advisable, like systolic BP between 120 to 130, like the patient with a very high risk group. In the ACCHA guideline, importance of the ABPM and home blood pressure monitoring also included, because it is easy to use home blood pressure monitoring, and it also correlate, and also it help to diagnosis of the mask hypertension, as well as it also rule out the white coat hypertension. So importance of the home blood pressure monitoring and ABPM was highlighted. Rather than office BP is most common correlate and it which used in the trial. So office BP should be part of the evaluation, but along with the office BP, ambulatory BP monitoring as well as home blood pressure monitoring also highlighted. First line therapy, same like beta blockers are now out. Newer definition. ESC guideline defined the category of the elevated BP between 120 to 140 systolic and diastolic is 70 to 90. Anything above this 140 by anything above the 140/90 is called hypertension, while AHA guideline define the elevated BP, stage 1 hypertension and stage 2 hypertension. We will discuss more here in ACCHA guideline because it's a recent guideline. So it define elevated BP between systolic blood pressure between 120 to 130 and diastolic between 70 to 80. Stage 1 hypertension defines systolic blood pressure between 130 to 140 and diastolic between 80 to 90, and stage 2 hypertension is defined as blood pressure beyond the 140/90. Measurement of blood pressure and significance of office, home and ambulatory BP monitor. So this is a very important slide, how we should monitor. BP cuff should be at level of our heart. Patient should be relaxed without the crossing the leg, back supported. Patient ideally should be given a 5 minute of the resting period, and after the 5 minute of the comfortable, then we should measure the blood pressure. Patient should not consume the tea, coffee or any tobacco like substance which stimulate heart rate and blood pressure. What should be ideal cuff size of the blood pressure? So blood pressure cuff, inflationary cuff should be at least 75 to 100% of the arm length and 35 to 50% of the width of the arm. So it should be, cuff size should be that it covers 75 to 100% of the arm length and 35 to 50% of the width of the arm. So this should be ideal cuff size. And both guidelines prioritize accurate measurement and recommend use of the out of office BP measurement by ideally ABPM, ambulatory blood pressure monitoring. If it's not feasible, then home blood pressure monitoring is also acceptable to rule out white coat hypertension and rule in mask hypertension. ESC 2024 guideline provides the detailed diagnostic threshold comparing the office ABPM and HBPM values and guideline on when to use each method. It's the same AHA guideline also. So this is very important point. Patient's bladder should be empty. Remove the tight clothing. If the shirt is tight and it has a tourniquet effect, and because of the tourniquet effect there may be falsely elevated BP. What should be routine investigation in a patient who found a hypertension? So these are the common tests like fasting blood sugar, fasting lipids, blood electrolytes, thyroid profile, blood creatinine, EGFR, ECG, and nowadays USCR, that is urinary albumin creatinine ratio, is also recommended. It's like same like in a diabetic evaluation. Electrolyte, not only potassium, sodium, but also calcium should be done to rule out parathyroid related disease. For a kidneys, the measurement of the creatinine in USCR. For the heart, ECG is a mandatory. Echo is not mandatory in every cases, but echo should be done where we found any symptom related to the cardiac, like arrhythmia, heart failure, or ECG abnormality which suggest associated cardiac disease. Then and then echo should be done. Echo is not compulsory. What should be advised this patient? Lifestyle modification. Both guidelines strongly recommended lifestyle intervention like salt restriction, weight loss, physical activity, limited alcohol, DAS style diet for prevention and treatment across the blood pressure. This is typical DAS diet which has a high in fruits and vegetables, because fruits contain more potassium and magnesium which has an antihypertensive effect. It also emphasizes on the whole grains and whole grains product like pellets. Also emphasize on the low fat or non-fat dairy products, because the dairy products has a high calcium and calcium has also antihypertensive effect. So milk consumption is also helpful. Diet should be in a low fat, low sweets. Sweets should be, sweet component should be less than 10% of the total calorie. So sweet consumption should be less. Fish can be acceptable, but less poultry and less meat. And limited alcohol. Here, up to the 2 packs per day in a male and 1 packs in a female is permitted, but not more than this. When to start treatment? So both guidelines given a recommendation of the threshold level when to start treatment. The threshold level become less as compared to the previous. Previously, it was recommended more than 140/90, but nowadays, as per the recent guideline, more than 130 systolic or more than 80 diastolic, we should recommend to start treatment. Conservative threshold is advisable in a low risk young adults. So this is very important slide. If the blood pressure is more than 140/90, directly should offer a antihypertensive pharmacotherapy along with lifestyle modification. Previously, it was recommended 3 to 6 month lifestyle modification, and then if the BP is elevated, then pharmacotherapy was advisable. But now, as per the recent guideline, because even the 130, more than 130/80 also carries a risk, guideline recommended to start pharmacotherapy along with lifestyle if the blood pressure is 140/90, even on a single visit, but not single measurement. Measurement should be at least average of the 3 to 4. So patient, if the patient's blood pressure was elevated on the office, patient should be instructed to measure at home by average of the 4 blood pressure, average of the 4 BP monitors, 2 in the morning and 2 in the evening, morning before breakfast and night time before the sleep. So average of the 4 should be recorded. Along with the office BP, home blood pressure monitoring should also be offered, or ambulatory BP should be done before starting pharmacotherapy. So not only single reading, but if the patient found a blood pressure more than 140/90, then along with the home blood pressure or ambulatory BP also showing the high 140/90 office BP or ambulatory BP or home blood pressure monitoring more than 135/85. So ambulatory or home blood pressure monitoring threshold is 5 millimeter lower than this. 135/85 home BP monitoring average of 4, or office BP more than, along with office BP more than 140/90, then it is time to start pharmacotherapy with lifestyle modification. If the blood pressure is less than 140/90, then we should see if the patient having a risk, because higher risk patient, even if the blood pressure is more than 130/80, we should offer a pharmacotherapy along with lifestyle modification. So if the patient having a blood pressure between 130 to 80 and diastolic between 80 to 90, but associated risk like coronary disease, heart failure, diabetes, peripheral artery disease, or addiction or strong family history of the CAD, then even if the blood pressure is 130/80, then we should start therapy along with lifestyle modification. If no risk factor, then patient should be given a trial of the 3 to 6 months of the lifestyle modification. If the blood pressure is persistently more than 130/80, then it's time to start pharmacotherapy. So this is the same, it's represented here. If the blood pressure is 120/70, like non-elevated BP, then only lifestyle modification is recommended. In the elevated BP, between 120 to 30 systolic and diastolic between 70 to 80, then lifestyle modification is recommended. In stage 1 hypertension, the lifestyle modification along with pharmacotherapy in a high risk patient, if the person is not high risk, then initial trial of the lifestyle modification, then pharmacotherapy. In stage 2 hypertension, straight away pharmacotherapy. So ideally, as per the recent guideline, the low dose combination therapy is preferred. Double combination therapy, either in form of the RAS blocking agent like AC inhibitor or ARB, with CCB or diuretics. Any two of the three medications should be start initially. It's a low dose double combination therapy, low dose here. Single monotherapy is recommended in an elevated BP category in a high risk cases, or moderate to severe fragility, or symptomatic orthostatic hypotension. In symptomatic orthostatic hypotension, beta blockers is a preferred agent because they had a less provocation of the orthostatic hypotension. Age more than 85, or expected life less than 3 years. In a if the person's expected life is less than 3 years, no point of giving aggressive therapy, because this therapy mainly give benefit on a long run. So these are the few indications where the monotherapy is preferred, like very fragile or very high risk cases. Otherwise, low dose double combination therapy should be started. BP should be monitored every 1 to 3 monthly, not every daily or not weekly. Because of the long half-life, the maximum effect is occur at least take a 10 to 14 days, any antihypertensive effect. So ideally, patients should be follow up every monthly, not 3 monthly. And after the 1 month, if the patient's blood pressure is beyond the target, that is more than 130/80, then low dose triple combination therapy should be preferred. So all these 3 drugs in a lower dose. Still after the 1 month, if the BP is not controlled, we can give a full dose of this all triple drug therapy. Still not controlled, then there is a role of the spironolactone, even beta blocker can be added here. At any stage, any step, the beta blockers, add the beta blockers if the compelling indication. So beta blocker is not a first line therapy, but if the compelling indication is there, then we should given a beta blocker even as a first line therapy, like the patient of the post-MI patients, low ejection fraction patient, angina, heart failure, or if the relative indication of the beta blocker is heart rate more than 80, because tachycardia also associated with high risk, or young sympathetic hyperactive individual or patient with a prone for orthostatic hypertension, then beta blocker can be added. So here, these are the drugs for a resistant hypertension. Alpha blocker, centrally acting drug like methyl-dopa or clonidine. Potassium sparing diuretics. Already spironolactone was added, but amiloride can be also added. Renal denervation class 2B indication if the persistent hypertension, because it reduces the pill burden. Timing of the BP medications. Patient above common question hoy ke kyare levi. So any time patient can take, but ideally the time should be same every day, not kyarek morning lithi, kyarek evening, but any time convenient time can be taken. The ACC recent 2025 recommendation, dihydropyridine calcium channel blockers, that is long-acting calcium channel blockers, AC inhibitors, ARB and diuretics, recommended as a first-line management in hypertension. Combination therapy in a single pill combination is recommended with any of above first-line agent. Management of the hypertension in a diabetes, because it's very common. Diabetic patients, 30% of the hypertension, 30 to 50% patient of the hypertension are suffering from the diabetes. So these are both are combined, go parallel. So both are the comorbidities, and what should be ideal management strategy. So in this management of the hypertension and diabetes, combination of the CCB and ARB is recommended, particularly CCB who has a antiproteinuric effect like cilnidipine. So this combination is preferred because both reduce the proteinuria, both has a survival benefit in a diabetic hypertensive patients. So rather than here the diuretic is a first this combination should be offered. And the target should be 120 by 80 because diabetic are a high risk. So rather than 130 by 80 here our target should be systolic blood pressure should be between 120 to 130. So little bit threshold should be lower here. So the both guideline has a little difference because the ACCHA guideline define the hypertension by stage 1, stage 2. This is because of this trial how it conducted. Let's see our Indian guideline. So this is done by the API guideline. Here the diabetic patients are defined according to risk category. Very high risk patients are diabetic patient with clinical established atherosclerotic cardiovascular disease or severe target organ damage. Severe target organ damage is defined as a EGFR less than 45 or macroalbuminuria, that is USER more than 300, or EGFR between 45 to 60 along with microalbuminuria. Then it's also defined as a severe target organ damage, or all the three microvascular complications of the diabetes like retinopathy, neuropathy and nephropathy. So severe target organ, severe TOD defined as a very high risk population. High risk population, the 10-year CVD risk between 10 to 20%, moderate risk between 5 to 10, and less than 5% risk is defined as a low risk subgroups. API guideline recommend the microalbuminuria testing is recommended to identify individuals who are at risk of the developing kidney dysfunction or risk of future cardiovascular disease. Along with the same like ACCH and ESC guideline, API guideline also recommended ABPM monitoring and home blood pressure monitoring. ABPM should be ideally preferred, but the disadvantage of the cost, otherwise it's correlate very well with the prognosis. It is a very accurate measurement. Home blood pressure monitoring is easy, so it can be used as a substitute but not as a replacement. API factor influencing cardiovascular risk, gender, male have a higher risk, elderly patient has a more risk, higher BP has a higher risk, smoking is a higher risk, family history, heart rate. Here also, if the resting heart rate is more than 80, then the hypertensive patient carries a high risk. Obesity carries a high risk. Diabetic carries high risk. Pregnancy with hypertension carries a high risk because of the adverse outcomes. High uric acid carries a high risk. Pollution, here is also emphasis role of the pollution. Pollution is one of the main culprit in every like not only cardiac issues but also cancer. So environmental exposure also carries a high risk. Goal same 130 by 80 as the previous guideline. CCBs to be used in combination with ARB. Newer molecule cilnidipine is recommended. Because of the cilnidipine has a antiproteinuric effect, it has a anti-aldosterone effect, also it has a sympatholytic effect. Because of the sympatholytic effect of the cilnidipine, heart rate is reduced with cilnidipine as compared to the most of the other CCBs in whom the heart rate is increased. So cilnidipine has a unique advantage as compared to the other antihypertensive other CCBs. Yoga is also recommended here, the new edition. So these are the novel CCB advantage. Already we discussed it. Also improves the insulin sensitivity, and insulin sensitivity, insulin resistance is a main pathogenesis in a diabetic patient. So cilnidipine has a role of the improvement insulin sensitivity. So it reduce the sugar level. It helps to reduce the obesity. So these are the take-home messages. Ensure the accurate BP measurement. Role of the ABPM and HBPM added, risk calculator added, considering the earlier pharmacotherapy in high risk patients, threshold level become less as compared to the one, previously it was a 140 by 92, now target is 130 to 80. Prefer a single pill combination therapy, tailor BP target to the according to age, fragility and comorbidity. More fragile patients beyond the 85-year age, BP target should be less aggressive. In diabetic with hypertension, prioritize combination therapy. ARBs and CCBs are a combination is preferred. Emphasis on the lifestyle modification. Here, role of the yoga, implements the team-based approach and recognize the regional difference. So, guideline may vary little bit. Thank you.